Good evening, everyone, and welcome to the first session of breast education with Learning General Surgery. So today we have Dr.Selvi Radhakrishnan. She's an excellent breast surgeon from Chennai, a great mentor with special skills and technique in imaging, oncoplasty, and everything that has to do with breast. I've had the fortune to both train under and work with her, and so we welcome her to the first session. Today, she'll be talking about lump in the breast, a case discussion. So we thought we'll start the first session in breast education with some case discussions. And
if we can talk about her education and training.
I haven't prepared that.
Maybe Dr. Selvi can. No,
okay, I'm going to share my screen now.
No, you can do it yourself, Dr. Selvi. Now, what makes you eligible to be a breast surgeon?
So, yes, education, about my education. So, I'm a graduate from Madras Medical College, passed out in 1989. And so, that was a time when DNB was relatively new. So, I did DNB Railway Hospital, Chennai, and then I moved to UK and did my fellowship there, worked for some years, then came back, did different things in India. Then I went back for another spell. For training in the UK. So that was a time when things were changing slightly. So for a very long time, there was only like mastectomies, Petty's mastectomy, and then breast conservation was coming into vogue, but nothing had changed much in our country largely. But around the early 2000, then I went back again to UK, and that is a time when the concept of sentinel lymph node was catching up in Europe, and oncoplastic surgery as well. So I spent some time picking up some skills, and I also realized the big lacuna in our country is standardized imaging. So I learned a bit of that as well, and then came back, and then trying to fit in an Indian practice scenario was challenging. You know, obviously I was too late to join the government service, and it was not easy to get in as well. And then in private practice, it is a challenge, and it has been an uphill climb, but over a period, like I have picked up some skills, and we have run some training programs to impart some of the skills that I could share. And then we've also managed to set up a good breast center in Chennai. So that I believe is on par with any good center anywhere in the developed part of the world. So of course, we have our challenges. We have some resource constraints, space constraints, and we have also to be culturally sensitive and relevant. So all of these put together, it's still a good service. And so this has been actually been planned for a very long time, but I did not execute it for various reasons. I always had some excuse or the other. So then we decided to put together. So I thought we'll run it over a period of time. So I'll just run through a few slides to understand what is happening in breast surgery, most of which revolves around breast cancer. And then we'll structure. So today, for today's session, I just picked up one case discussion, but that's kind of only a sample. Most importantly, from the feedback that I get from people logged in and other, so to understand what is the need and how we can structure it and go forward. So I thought we'll take a plan like 2022. So we've in January now, so we plan about 52 to 55 sessions. It will be a full year's program. and we could cover a lot of ground in understanding not just breast surgery, but breast cancer as such, and other breast disorders. You know, a good surgeon should have a good understanding of benign breast disorders as well. So, involving imaging, pathology, surgery, adjuvant treatments, follow up, and all in a very structured format. So it all depends on the feedback that I get. So I would structure it, and then we will take it every week on Saturday, same time. So just to get it going, I just wanted to give a small introduction about how breast surgery has evolved over a period of time. Very early on, the beginning of say 2000 AD, the 200 AD, 300 AD, this was the Gallen's hypothesis, where they thought breast cancer is related to uh, bile, black bile. It's just like how in Ayurveda you have Vata, Pitta, and Kapha. This early Western medicine also had this theory surrounding phlegm, bile, and such. And this overflow of black bile was thought to be breast cancer, and that theory ran on for a very long time, uncontested. And few things here and there happened, you know, some gory images. If you look at it, some guillotine amputation for breast, where there's a kind of snare, and for breast tumors, people use that to remove breast, and all sorts of images if you look back in the history. But you know, with the advent of anesthesia, with the advent of antiseptic, surgery evolved, and as a whole, breast cancer surgery also evolved. And this everybody knows this picture of William Halsted. So for about 100 years, Halsted's radical mastectomy ruled the roost, and was one of the most successful surgical procedures ever done. And the people did do well, women did well. But what happened, with all the radical procedures, the quality of life was miserable. So the most of them had massive lymphedema and very deformed chest, and very poor quality of life. And in the 60s, this gentleman, Dr. Veronesi, and he just recently, a few years back, 3 or 4 years back, passed away from Milan, Italy. And so he was a pioneer, and he became an advisor to the government, and he started this European Institute of Oncology. And so he was the one who started the early research on preserving the breast. And so the trials of quadrantectomy, lumpectomy versus mastectomy all came out of Italy. And it showed that, and then the axilla trials as well, showed that breast conservation was not inferior to mastectomy. So that was a trendsetter in the 1960s and early 70s. And then came Bernard Fisher. So it was all dominated by surgeons. Management of breast cancer was dominated by surgeons. And the incidental discovery of nitrogen mustard during the World War. And so they found some use of nitrogen mustard gas in treating cancers. So medical oncology developed, and in the 1970s, the whole range of NSABP trials started. So they started with BO4 and then BO6, a very famous axilla paper, and it's still very well done trials, and this actually revamped the whole thought process of treatment for breast cancer. So there was a very, what we call as a paradigm shift from what we thought it's a surgical disease, removing it extensively cured the cancer. It was a shift to, no, it's not local disease alone, it's systemic disease, and it's systemic disease that kills, and we have to do something about it early on. And that concept, the systemic hypothesis concept, came about with research surrounding this gentleman's work, Bernard Fisher. And continuously, even today, there are NSABP trials going on. So, so this was a big landmark change that happened in the 1970s. And then it was, you know, slowly the systemic therapies were taking over breast cancer management, and then surgeons were just seen as technicians, just operate and then leave the patient to us and we manage. So that is, we must have seen even now. And with the advent of systemic therapy, it was still very blindfolded, and you give different combinations and see which one works. There was a lot of toxicities, of course, and then with the lot of understanding of the biology of breast cancer as well. So the markers like estrogen receptor, progesterone receptor, epidermal growth factor receptors. So a lot of research around HER2 was done, and this gentleman, Dennis Slayman, he was the one from UCLA who worked extensively on HER2, the epidermal growth factor receptor 2, and then was instrumental in developing trastuzumab, which is one of the earliest monoclonal antibodies. So first of the targeted treatments was actually hormone therapy. So the tamoxifen was the most commonly used adjuvant hormonal therapy, and this was targeting this estrogen receptor. So that technically will be the first of the targeted therapies. That was chemotherapy that was not targeted, and then with the advent of understanding more about HER2, and he developed the monoclonal antibody called trastuzumab, commonly known as Herceptin, the trade name. So this trastuzumab administered for HER2 patients, they did extremely well with because overexpression of HER2 was known to be a very aggressive breast cancer. So 30% of women with breast cancer expressed HER2, and whenever HER2 was expressed, so they all had poor prognosis, and these people needed to have anthracyclines and a lot of had poor outcome in spite of having aggressive chemotherapy, second generation and third generation chemotherapy. With the advent of trastuzumab, the whole picture changed, and in fact now with the current AJCC classification, HER2 positive patients actually with anti-HER2 treatment, the staging has actually come down. There is a stage migration to the lower end of the spectrum, and then the prognosis is really good with anti-HER2 treatment. And then came the understanding of whether a lot of research is going along the way towards understanding the genetic aspects of breast cancer. And Mary Claire King was one of the scientists who was working on breast cancer genetics, and she was instrumental in finding out and locating the BRCA, what we commonly call as BRCA, BRCA gene, mapping to chromosome 13 and chromosome 19. So she paved the way for understanding breast cancer genetics. And then came, obviously quality of life became more important because with the advent of targeted therapies and understanding a bit more of biology, we treat with the advances in all the systemic treatments, people tend to live longer. And obviously then quality of life issues matter, and then people started looking at, can we do less with surgery? Can we do lesser of axillary management? Because all along, complete axillary dissection was the norm. So removing 30 nodes, 40 nodes from the axilla, and there was a good amount of discordance between clinical axillary assessment and the pathological axillary outcomes. So assessment. So therefore, there was a need to assess the axilla adequately, appropriately, and do less as far as axilla is concerned. And so this gentleman actually paved the way for understanding and doing sentinel lymph node biopsy, Armando Guglielmo. So now, so much so that for a clinically and radiologically node negative patient, doing a complete axillary clearance is not on. Sentinel lymph node biopsy is the standard of care over the last 15 years now. This is the standard of care, and we should strive to set up a sentinel lymph node program for wherever we practice. So this is a brief history of the advancements in breast cancer management in the last century. So breast as a specialty, because as we understand, even now in our country, breast is it's not considered a distinct specialty, and everybody does breast, from obstetrician gynecologists to plastic surgeons and general surgeons to surgical oncology, a whole range of people doing breast work. So obviously the reason being, it's a surface organ, it's not a cavitary organ. Save for the axillary vein and the LD pedicle and the nerve to serratus anterior, there's nothing vital there. It's one of the easiest uncomplicated surgeries to do. So people take it lightly, and if there is a lump, take it out as a concept even now in many places in our country. So this led to poor outcomes. So what was happening in the West in the 1990s, people understood that for not just breast, for all organ systems, overall survival increases with specialization of the doctors involved in the diagnosis and treatment. And there were a lot of studies, and so there was one significant paper in British Journal of Surgery. We looked at survival outcome of care by specialist surgeons in breast cancer. We looked at a large number of patients in west of Scotland, and they said, and the paper clearly came out with a conclusion that the overall survival is better when the doctors treating breast cancer are specialized in that area. So, and all major studies that came after emphasize the fundamental role of multidisciplinary care in improving patient survival. So this breast was a trendsetter for all other organ systems. So when most of the studies super specialty, subspecialization started with breast. So particularly relevant to imaging and pathology. So then this led to development of specialist breast centers, where the lead role is played by surgeons, and there is a definite multidisciplinary approach with the radiologist, with pathologists, with medical oncologists, radiation oncologists, and nurse practitioners who specialized in nursing care associated with breast cancer work. So all disciplines evolved, not just breast surgery, where we talked about preserving the breast sentinel lymph node biopsy and achieving better cosmetic outcomes. Breast radiology developed as well. So from doing a conventional 2D mammogram, it's interesting how radiology developed. So this team of pathologists who actually, once the breast was removed, radical mastectomy was done, they did specimen X-rays of the breast that was removed. And so originally it was all the regular X-rays that was used to image chest X-ray, and then they developed fine-tuned it. They developed soft tissue X-rays to explore breast, and then from then came understanding how to image the breast. So the initial analog machines and the understanding about positioning, getting optimal views of the breast. So like we know that any body part is imaged in orthogonal planes. So at 90 degrees to each other. So in breast, obviously 90 degrees to each other would be in a craniocaudal and a lateral view. But a lateral view will miss out a lot of breast tissue in the upper outer quadrant. So then they gave a tilt, a 45-degree tilt, and then you develop this. They developed the standardized mediolateral oblique view. So an analog from the analog mammograms, where they actually have to load a cassette that is loaded with the film, then the film is exposed. So there could be a problem of overexposure, underexposure, or lack of compression. Patient moves a little bit, and the film is wasted, the exposure is wasted, because then you develop and see, it takes time to do, and then you come back and redo the image. So all this is very time consuming, also too much of radiation exposure as well. And then the problem of storing these films. And X-ray films degrade over time, and then these films are not available for comparison. So all this was going on for a very long time. And then they developed, this Fuji very cleverly developed computerizing all these images. So what they did was the X-ray cassette was still placed, but the images were converted into digital images. From after acquiring it on the cassette, this cassette was then actually processed to give a digital image, and then storing them became easy. But then there was some loss of information while you actually change it to a digital image. So then more research, actually, just like how our when 30 years back we all played around with all these cameras where you had to load in Kodak and Konica films, give it to a lab, develop it, and then put prints. And then we started using digital cameras, and then the camera actually improved, and now we have 14 megapixel, 18 megapixel, God knows how many more megapixels will come. But the clarity of the images got better and better with digital images. And similarly, for breast, digital mammogram came into vogue, and that's about 15 years ago. And then there's the problem of imaging a three-dimensional organ, a conical pear-shaped organ. And when you do a classical mammography, you're compressing it in 2 dimensions, in a CC view and an MLO view. So what happens, a three-dimensional view gets compressed, and there is a lot of superimposition of tissue overlapping on itself. So that sometimes gives us pseudo mass-like lesion, pseudo speculated lesion. So then again, this was particularly relevant in screening, where women did not have symptoms and they went proactively to get their breast checked, and then they have their mammograms like this, and they get called on because there is some pseudo overlapping tissues, and calling them back for additional tests increases anxiety, all the false positive related issues. So then to overcome that, and then we also had some CT imaging for the rest of the body, like thorax, abdomen, brain, and you could reconstruct the images in many ways with the CT images. So with that, they combined the principle of seeing the images in different sections along with the mammograms, and then the STOMO developed, where the detector actually sweeps the entire breast over a 180-degree axis, and then you get breast sections in different cuts, and then all of these is superimposed in, so you can actually see all those different cuts, and you can also synthesize a 2D image from the tomo. So therefore you can actually now with the synthesized image, you can reduce the X-ray exposure that occurs with tomosynthesis as well. So all these are recent advances in breast radiology, and then MRI cannot lag behind. So functionally, how MRI is different from mammogram is that mammogram images is static, it's not dynamic, and two, the changes that are seen in mammogram are because of structural changes that happens in the breast. Majority of them, like for example, calcifications. Calcifications happen when there is dead tissue anywhere in the body. So when there is tumor necrosis, the necrosed bits of tissue gets calcified over a period of time, and this is what you see as calcifications on a mammogram. You don't see the biology of the disease. You can indirectly infer some biology of the disease based on the mammographic appearance, but there is no dynamic assessment on a mammogram. Whereas with the MRI, when you give contrast, gadolinium is given intravenously, the rate at which the contrast is taken up by the tumor reflects the tumor vascularity, the vascular pooling, and the arteriovenous shunt that happens because of neoangiogenesis in the tumor, and the rate at which it's washed out because of the shunting. All of this gives us an idea about whether this is likely to be malignant, how aggressive is this, and all these, and then the extent of the disease, and so it gives us a lot of information. It's particularly useful as a problem-solving tool to assess the extent of the disease, to assess response to therapies, and in high-risk screening. So with all these imaging advances, then we started picking up disease at a much earlier stage, and when it is not clinically palpable, and therefore we needed image guidance to do biopsy. So all the image guided techniques evolved. So all of this developed in tandem, and I did put, I should also mention a few words about ultrasound. So this, again, there's a lot of development in the B mode ultrasound that happened over time with sharper images and with all the noise control, with all your harmonics, spatial compounding. So all of this gave a clear picture, so which actually you could actually delineate a lesion very nicely and look at the normal anatomy also very nicely. And then specifically to cancer, then for breast, a software called elastography also was developed. So there are different types of elastography, strain and stress. So basically the principle is based on the Pascal's law. So any tissue has some amount of elastic potential, and the benign lesions are very elastic. So it's basically when you compress and release, there is some amount of elastic potential in normal tissue and in benign tissue. Whereas in a malignant tissue, particularly in squamous type cancers, there's so much of fibrosis and hardening around the tumor that you study the elastic potential, you can see that it is very stiff. It's not as elastic as the normal or the benign tissue. And the stiffness is measured, and so it is color coded based on the vendors, and it gives an idea about whether it could be malignant or not. And also assessing flow, blood flow. So any tumor that is rapidly growing will need blood supply, and you can actually image the blood flow into the lesion, and the types, the patterns of the blood flow, all this could indicate whether it is malignant or benign. So these are all the developments that happened with radiology, and pathology cannot lag far behind. From using only the gross pathology, then we moved on to looking at immunohistochemistry, studying a little bit of biology of the disease, whether it's estrogen sensitive, is it expressing HER2, and a whole lot of other markers. But these three markers are standard markers, and now we've learned to adding Ki67 has had some advantage. And then this Peru's molecular classification. So based on all these permutation combinations of ER, PR, and HER2, we have luminal A, luminal B, HER2 enriched, triple negative. So these are the basis for molecular classification. And then we understood a bit more about genetics and breast cancer. So about somatic mutations, which drives the precision medicine, because you can give a bit of tumor tissue and they run through some tests, and then in a couple of weeks they give you a result which says, this is overexpressed, this is sensitive to this chemotherapy, this is resistant to this chemotherapy, and you can actually now decide your treatment based on somatic mutation studies. And of course, germline mutation to understand the susceptibility to breast cancer, and managing breast cancer in patients with mutation, and managing women with mutation who are mutation carriers who don't have breast cancer yet, but who are high risk to develop breast cancer. So, and then digital pathology labs are also in vogue now. This has also come up in some places in India as well. And then medical oncology, of course, with it started off with CMF and cyclophosphamide methotrexate and 5-fluorouracil. So this is what we started with when we started treating breast cancer in the early 90s, and then from there at adriamycin, anthracycline, came about, and anthracycline has its own disadvantages, cardiotoxicity, and so a lot of other treatments which mitigated that cardiotoxicity effect of anthracycline came about, and then the development of Taxol and so taxanes in general, paclitaxel and docetaxel. So that's what we call as third generation chemotherapy. And from there, like I said, mentioned about targeted therapies, the first of which is estrogen related targeted therapies and HER2 targeted therapies. And now we have targeted therapies for other markers as well. But the most effective one is still HER2 directed treatment. And radiation oncology developed as well, from cobalt to linear accelerators and image guided radiotherapies and a concept of partial breast radiation. And now people are talking about proton therapy as well. So you can see how every bit of multidisciplinary development of everything came about, all happening in tandem around the same time. So one contributing to the other. So this model, extending this breast cancer model for other cancers, was the biggest achievement in the last 20 years. So all other cancers as well developed, and the basis for all other multidisciplinary care models started off with breast. So the essential steps would include, I'm not even talking about screening here, it's concentrating on diagnosis. The screening and diagnosis are two different areas and areas of skill, expertise and training. So we're not going to discuss screening right away. We'll come to it at some point in time later. But to start off with, the diagnostic process, and from which we have enough information to make decisions regarding treatment plan using standard guidelines, tools, and then developing technical expertise in surgery, the different surgical approaches, and follow and integrating multidisciplinary care. So right from jumping into surgery immediately, now we use a lot of neoadjuvant treatment to facilitate surgery. So this is very important to understand the multidisciplinary role in management of breast cancer. And then follow-up and survivorship. So it's not enough we just operate and leave it all to the medical oncologist to follow up. So surgeons do have a big role in follow-up and attending to survivorship areas, particularly in managing arm-related issues. And then we have to keep evolving. Research, surgeons have to take part in research and obviously training. So this is very fundamentally important as well. So as we train, we learn. So this is the kind of structure that I thought we will use for on this session in LGS. We've identified Saturday. This time is most optimal for all of us, I guess. So it's a structured approach for over a year, assuming we're starting in the middle of the year now, about 52 to 55 weeks. And so we will have case discussions, some imaging sessions, or I've already done some imaging sessions in the past. It's all scattered, so maybe I can do some again in an organized fashion. Understanding staging and relevant to the staging that we follow now, the pros and cons of the current AJCC 8th edition staging, treatment planning, surgical aspects, adjuvant treatments, and follow-up. And obviously, we won't leave away the other breast diseases, understanding benign breast disorders, duct discharge, fibroadenomas, cysts, phyllodes tumors, simply dealing with breast pain. And then obviously, I should include screening here as well. So all of this we will do. We will bring in resource people from other parts of our country and maybe from outside our country too, to coordinate some of the other sessions as well. So I would stop here and take feedback. So can I just stop sharing and then I can come back again? So I just have one case to discuss today, but I can take feedback about what the group feels about what is needed. in these sessions.
Dr. Anjali, if you can start.
Yes, good evening, Dr. Selvi and Dr. Patta sir. Good evening. Actually, I joined late, but whatever I could recollect, I have been trained under Dr. Selvi long back. He must be remembering. I have met often in the various APSI meetings. Am I audible, sir?
Yeah, you are.
Yes. Dr. Selvi must be remembering me. We met often in various APSI activities and various breast activities. So on this forum, as I could recollect, whatever is the vision of the LGS forum and rest of the dignitaries, it is for the beneficiaries of the PG students, if I am not wrong. So taking into consideration of the benefit for the PG student, actually they have a long case of the carcinoma breast and they have a short case of the benign breast disease. So depending upon this, to how you reach to a diagnosis, how you reach to a diagnosis, your approach for the diagnosis of the lesion, that is one aspect, Dr. Selvi. And the second thing is, as you have said, that the total 52 lectures will be taken. In spite of that, what I would suggest that case-to-case discussion and how should be your approach, that is one aspect. Secondly, if you are planning to educate about the young practitioners, that how should be your approach for the surgical management when they come into practice, then that is a different aspect. So this is my view, Dr. Selvi.
Yes.
Dr. Santosh John Abraham, the teacher of teachers, is here, but he's joined a bit late. But he is the one who's restructured surgical education in India. I had asked him to unmute and comment, sir. Santosh, sir.
Thank you.
How are you?
Good evening. Yeah, I'm fine. I'm fine.
Yes, sir.
And it's always good to listen to both Patta as well as Selvi. I had the pleasure of working with Selvi.
I should say that, sir.
Anyway, probably I was instrumental in instilling some interest in you in breast. Okay. Anyway, I mean, it's a good initiative, Dr. Selvi. I was just only wondering whether Saturday would be the right time to do this. That's my only suggestion. Maybe somewhere, because it's a weekend, towards the weekend. That's my only apprehension.
If RK gives me another slot some other day, yes, sir, certainly. He gave me Saturday. I think he's booked all of.
And
That's
this is a very important thing. A lot of people told me, I mean, Santosh is a seasoned surgical teacher. He knows what is the right time. So any day other than Saturday, Sunday will be. Sir,
I think weekends people will have their own personal, agenda, like family, maybe outing. So if you are going to have a very structured program, if somebody is very serious about this attending, I would think that you should shift it to a middle of the week or some weekday so that people are at ease to attend. That's all my suggestion. And, as Selvi has rightly put it, the concepts have to change. And of course, case-to-case discussion is possible, but then, one should stop the habit of thinking that every breast lump has to be excised. That kind, from there onwards, we need to start. So conceptual, teaching would be very, very important in these kind of settings. That's all my suggestion is.
Yes, sir. So we'll figure out an alternate day midweek, sir.
Yep. Think about it.
Certainly, sir. Certainly, I think this is a very, very valuable suggestion.
Except Wednesday, where we are going to roll out with our skill enhancement program and didactic lectures by the ASI, which you will be part of it in any case in one of the teaching sessions in any case. So,
Sure, sir. Your suggestion is well taken. Dr. Rudra, you want to comment? If you can unmute and come. Dr. Shireen from Pakistan. Dr. Asha, you would make some comments?
Asha?
Yes.
Anything else that you would like to add, Asha?
No, I think that's it. So it was a good introductory class today. And I think we can structure even case-based, like, do one early breast cancer, one locally advanced breast cancer, and we can split it into case-based discussion so that for PGs also it's easier to understand and help them in that way as well. And then we can also integrate imaging and other things for early practitioners to help guide practice as well. I think we can split it into a couple of sessions like that.
As one of the admins of learning general surgery, my suggestion would be we need to cater to every section of surgeons, mainly students of surgery, and then also practicing surgeons, because this looks like a very, very light specialty, and with lots of girls taking up surgery. As I was commenting, now the MBBS entrance 70% are girls. It was 7% in 1947, and with that, a lot of surgeons are girls these days. For a lot of surgical chiefs are girls, and I think they have to rekindle very special interest in this breast area, because as you also see that breast disease are so very common in India, especially breast cancer, which is comes 10 years earlier than the rest of the world, and so much improvement in breast imaging and so on. And he has shown the various subspecialties that deal with breast. So my suggestion would be, I think Dr. Santosh is a wonderful suggestion, because Saturday is a holiday, at least it starts, partying starts then. So I think we need, because we are doing other programs other days. Monday is a possibility. Friday is also a possibility. I think I'll discuss with Dr. Selvi and I'll get back to that. A case discussion is mandatory. At least half the time should be a case discussion. One image, what is new in breast disease must be another 10 minutes. And finally, literature. It's what is special in literature, and then I also feel that two, three other specialists should come in, and if there's a suggestion given to me or Asha, we can work on that, and we will structure it in a very attractive manner so that it helps everyone. Asha.
I think Dr. Shireen has also put that she asked, can we combine it involving our specialty too? So
I didn't get it. What is that?
Dr. Shireen has also messaged, I think her mic is not working.
Yeah, Shireen, yeah, definitely.
Hello, sir.
Yes, Shireen, I had to tell you the story by what happened when the last breast meeting had to be postponed. I'll come back to you on that, but it most welcome. It'll be nice if, one of the surgeons can feature for a while in every meeting. I'll coordinate with you, Shirin, and we'll do that. Definitely.
Thank you, sir. Thank you.
Any other comments, suggestions from anyone? Please unmute and. Yeah, Dr. Selvi, you have time for your case discussion?
I just have a small case, so I will just run it through. Okay, so I stopped here. So I just have a So to start with, I just put a case together for discussion today. So I have a 64-year-old lady, postmenopausal, obviously, mother of 3 children, breastfed all. She presented with a right breast lump for 10 days, which she noticed for about 10 days. There's no family history of breast or ovarian cancer. She had no comorbidities, significant comorbidities or allergies. So and then, yeah. So on examining her, she was actually good performance status. She had a palpable lump that was about 2 by 1 centimeter in the right upper quadrant, 11 o'clock position, and no skin or nipple areolar involvement. She had it was a D cup breast and grade 3 ptosis. There was no palpable axillary nodes. The other breast and axilla were normal. So she obviously had a mammogram. So I'm just going to run it through today, and then obviously the discussion bit and all that we can do in detail in future sessions. So this is a synthesized view of a tomo mammogram, and this is craniocaudal view, and this is shows a spiculated mass lesion. You can actually see the spicules here. This is so when do you call a mass on a mammogram? When you see a lesion both in a CC and a MLO view. It should be seen in 2 orthogonal views to be called a mass. This is a rule for every imaging and particularly relevant in mass in breast. Because if you see a density only in one view and don't see the density in the other view, then it is not defined as a mass. It's called an asymmetry. So that has a different evaluating protocol. But if you see a lesion that is, we are able to demonstrate it both in a CC view and in the MLO view, then by definition it is a mass. So this should correlate with what you are feeling clinically, location wise. So we'll talk about that location later. So this is a lesion, spiculated lesion that is high density in the outer quadrant of the breast. Why do I say outer quadrant? Because this is a nipple areola that is in the center here. This is a CC view, and conventionally the marker RCC or LCC is placed in the outer aspect of the film here, the digital film. So if you draw a line to the back of the film from the nipple areola, this half is the outer aspect of the breast, outer quadrant of the breast. This half is the inner quadrant of the breast. So this is in the lesion is in the outer quadrant of the breast. So this is the MLO view. So and a word about the density of the breast. So that by using the standardized BI-RADS language, you have 4 types of breast. One is that predominantly fatty breast. The second is mixed, that is heterogeneously dense breast, extremely dense breast, and what's the other one, Nasha? Oh, forget. Anyway, I'll come to it later. So this is the MLO view. So the MLO view, you see that. Why do you call it MLO view? Because this has a pectoral muscle that you see. So this is there is a 45-degree angle that the gantry takes to include the pectoral muscle in that lateral view. So that is why it's called the mediolateral oblique view. So this is the pectoral muscle that you see. And if you see, to tell whether the breast is imaged optimally, because if the technologist doesn't position it adequately, you may not actually get the whole of the breast imaged in that MLO view. So how do we judge whether the positioning is appropriate or not? You draw a line from the nipple position in the MLO to the back of the film at right angle to the edge of the pec muscle that you see. So if you draw a line like that, and that line meets here the pec muscle here, the edge of the pec muscle, there where it ends. And this line should obviously not be, it should be at right angles. If it is very obtuse or acute, then that means that enough amount of axillary tissue has not been included. So it is very important to include all of the breast tissue because 70% of all the breast cancers that you see are likely to be located in this area. This, if you draw a line parallel to this edge of the pec muscle, you draw a line parallel, say approximately 3 finger breadths away from this edge, draw an imaginary line. This area is the retromammary area. This area is likely to have most of the breast cancers. It's particularly relevant in screening situations where woman does not have symptom and you're looking for breast lesions. So, including this area is very important in a mammogram. So you judge whether the mammogram has been positioned well and technically adequate, and then start reading the mammogram. So we obviously see a mass lesion here, and then this corresponds to the mass lesion that was described in the clinical examination, and then so you do an ultrasound scan. So you look at the axilla here, there are no significant big nodes that are seen. The rest of the breast looks normal. The other side also looks normal. There is the skin, nipple areola, there is no edema. So, there is no other significant lesions in either of the breasts, in the other breast. And then you do a ultrasound. So this is an ultrasound. If you look at it, there is an irregular hypophoric lesion. And why I call it irregular? So when you define a lesion on ultrasound, there are only 3 shapes possible according to the BIRADS language. It's either oval, round, or irregular. So this is not oval, this is not round, so it has to be irregular. And as far as echogenicity goes, it can be hyper echoic, which is hyper means more echoes. So it will be bright like that, or hypoechoic, where there is less echoes. So it is darker. So this is hypoechoic. Anechoic, no echoes at all. So it should be pitch black, which usually happens when there is fluid, cyst, or it could be isoechoic, same as the rest of the fat. So you will learn as you keep seeing these images. So you describe the echogenicity, you look at the margins. The margins also are irregular, the shape is also irregular, and then it is also slightly vertically oriented. If you see the dimension across the horizontal dimension versus the vertical dimension appears to be more. So what we call as taller than wider. And then you look at what is happening beyond. So beyond, you look at acoustic shadowing, no shadowing, and acoustic enhancement. Here there is some edge shadowing. There's not much of acoustic shadowing here. It is mostly normal. But one other pathognomonic sign in ultrasound is this angular margin. So if you have angles, when you look at a lesion, always think of, so there's one angle here, there's another angle here, there's another angle here, and another view, there is an angle here. So whenever you see an angle in an ultrasound image with a breast lesion, the index of suspicion for malignancy should be very high. So, and then you put a probe, you put a Doppler, and then check for vascularity. When you put a Doppler, don't compress the lesion too much because it will occlude the vessels and you may not get a clear picture. So when you put a Doppler, the pressure should be a little less. And then you see actually a nice little twig of blood vessel that is going into the lesion. So this is the feeding vessel to this lesion, and this is significant. And then you look at what I told you earlier about elastography. So this is this is a shear wave elastography. So different vendors have different techniques. There is plain elastography. This is shear elastography. So if you actually the color coding is blue for normal tissue and benign tissue. So when you have stiffness, the color coding is represented from varying shades of yellow to brown. And when it is dark brown, it usually means there's a lot of hardness in this lesion, and this is very suspicious for malignancy. So this is a lesion that one definitely has to biopsy. And then we obviously, whenever you examine the breast, always look at the axilla as well. So when you look at the axilla, there is that you find a node here, and this node, this is a large node. It's a fatty node. So because it is hyperechoic here, and you see a thin rim of cortex. This rim of cortex is uniform. There is no irregularity in this cortex, and it's not thickened too much. So this is a normal looking node. So this is a early lesion, small lesion around 2 centimeters or less than 2 centimeters, no significant lymph node. And this is a lesion that one definitely has to biopsy. So biopsy was done, and it was invasive duct carcinoma, grade 2. So why a biopsy over FNAC? So it keep repeating time and again, and all of us keep talking about it. Core biopsy gives accurate diagnosis. So particularly if it is image guided and you know where your needle is going into, core biopsy gives accurate diagnosis. The problem with fine needle aspiration cytology is very false positive and false negative rates are a problem with FNAC. It is very technician dependent, and so the smears can be inadequate, the smears can be bloody, and therefore it actually puts the cytologist in a difficult position to give out a diagnosis. And even if you have a clear diagnosis, you still cannot do your IHC markers, because having the IHC markers upfront actually helps you in treatment planning. So here she's ER positive, PR positive, HER2 negative, and Ki67 is slightly high, 34%. And then, so this lady, we discussed treatment options. She had a large breast, small lesion, and in the periphery of the breast, 11 o'clock in the outer quadrant of the breast. So she underwent a simple bilocal excision, and because there is no significant axillary lymph node, we chose to do a central lymph node biopsy, and this is the pathology. So it's a 1.9 centimeter tumor in its maximum dimension. So the grade was a little, when you look at grade, you look at, there is sometimes, you get a large, the entire lesion, there might be an upgrading here. So it was grade 2 in core biopsy, but the final grading is grade 3. The margins were clear and central lymph nodes were negative. So according to the AJCC classification, it's T1N0 sentinel lymph nodes. And so this is a situation where clinically we do not have to do a PET CT for evaluation for metastasis, because 1, it's an early cancer, 2, node negative, 3, strong ER positive. So the likelihood of her having a metastasis, distant metastasis, is less than 2%. And so therefore, technically a PET CT is not essential. In fact, no staging workup is essential except for your routine bloods and chest X-ray, which is a part of anesthetic evaluation anyway. So this is what we did. And so I just close here. I just show an adjuvant tool that can be used when you develop, when you assess these situations for adjuvant therapy. 1 second, am I sharing the screen now?
No, not yet.
So this is a very handy tool. It is a predict score developed by the NHS, and so this actually you can enter all the details, and it gives you a very clear picture in a way that you can explain to the patient, and it's understandable for the patient as well in deciding whether adjuvant therapy and what adjuvant therapy and what are the outcomes. So this particular patient, no DCIS, so she had invasive cancer, so I put no here. She was 61 at diagnosis, and postmenopausal, yes, CR positive, HER2 negative. So Ki67, anything more than 10% is considered positive, so I say positive here. invasive tumor size was 1.9, so 19 millimeters, tumor grade 3 finally. It was detected by symptoms. She came with a palpable lump, so 0 nodes. And then you look at treatment options. Hormone therapy, you can look at 10 years of hormone therapy. And so chemotherapy, you look at third generation chemotherapy, and you would actually, when you put her on letrozole, you will give biphosphonates. So with all this information, these are the possible treatment options that we're looking at. With all this information, you can look at the results here for 10 years. So in terms of a table here with only surgery, so this is based on all the previously done treated patients. It's a validated predict score. So with only surgery, a good 70% survive 10 years. With addition of hormone therapy, you have an additional 6% benefit. 76% of people survive 10 years with addition of hormone therapy. With addition of chemotherapy, you would improve that by another 5%. And adding biphosphonates would improve that by another 1.5%. So this gives an estimate of what your treatment is in addition to. So you see, as far as surgical treatment, it's still the mainstay of treatment. Surgeons do cure cancers. Addition of other treatments provide incremental benefits. Obviously, discount these benefits. It is still you get the chart like this. So this is very easy for a patient to understand. When you show that what you've done as surgery takes care, this doesn't, obviously this predict score does not take into account of radiotherapy. Radiotherapy, when you do breast conservation, is mandatory. We're not bringing in radiotherapy here. This is only for targeted therapy, hormone therapy, biphosphonates, and chemotherapy. So without this, the same table that we read out is given as represented in a bar diagram. So it also provides you additional information. So this is the likelihood of patients succumbing to breast cancer. So you're upping that with your additional treatments. This can still happen. So this, particularly in our situation, it's important to consent and show these patients all this information. Because all our patients, we keep talking about all these, the expectations from surgeons, expectations from doctors are sky high. And any disease recurrence is seen as a surgeon failure or doctor failure. And then they go pillar to post, seeking second opinion, other modalities of treatment. Realistically, this also should be educated that, we are not, you cannot get 100% results. And this, above the broken line, is the mortality that can happen simply because of age due to other reasons. So this also puts things in perspective. This is a very useful tool that can be used to counsel patients regarding adjuvant therapy. And so I just wanted to show this. And it's good for us also to understand the realistic value of different treatments. So I'll stop sharing and I'll stop here today. So it's almost 9 o'clock. So this is the kind of pattern that I thought I'll take it through. So with case discussions and bringing in imaging, bringing in other aspects of treatment. So we'll learn as we go along as to how to take this forward as well. So thank you very much for the time and the attention.
Thanks, Dr. Selvi, for your wonderful talk and exposition on what is needed in learning all about breast disease and breast cancer. If any comments from anyone, please unmute and comment before we close the session.
This predict tool is an online tool. You just have to Google predict score breast, and it pops up that thing on Google, and you just press on it. It's self-explanatory. You start logging in all the details. You get all these various ways of looking at this information.
Santosh sir, yes.
Yeah, Selvi, the literature says that the chance of local recurrence is 1% per decade of life in breast conservation. So in a elderly female like this, after the age of 65, what is your advantage of even giving radiotherapy, even if you have done a conservation?
So the thing is, one, sir, that she is good disease. She has a B cup breast and a very small tumor. And we do a mastectomy for her. She's going to be lopsided. One thing that what I have looked over a period of time, no age is easy to lose a breast. Even a 60-year-old.
No. I was talking about even after conservation. What is the benefit really by doing a radiotherapy to the
radiotherapy? There are a couple of studies. The CLGB 9363 trial early on 10 years back itself, they identified a subset of patients who don't need radiotherapy. If it's a grade 1 mucinous tumors, grade 1 node negative tumors, these are patients who would actually probably not have any additional benefit with radiotherapy. So, but this lady,
this is grade 3,
was
grade 3,
and PR was low. So strong ER/PR positivity also is an important factor. So in her case, PR was low and Ki67 was slightly high, and it was grade 3. And so with the advent of hypofractionation, and with this COVID times, actually, we've started also adopting fast forward, which is just 5 days of treatment. In good risk people, particularly this borderline radiation indication people in elderly women, 5 days of fast forward works wonders. And it's good for the hospital because the turnaround time is quick for them and they can use the machine time for other patients. Cost effective and very good for patients, and it also motivates them for you can motivate them for breast cancer. The major deterrent for breast conservation is the need for radiotherapy, and that and obviously fast forward is still not applicable for a lot of situations, but hypofractionation, giving 15 days of radiotherapy is also actually improved our breast conservation rates. So this yes, there is a small subset, I agree with you, small subset of patients who are low-grade tumors, mucinous tumors, strong ER/PR positive, node negative. All of this put together, if could be an indication to avoid radiotherapy in elderly people over 70.
Thank you.
Dr. Prakash, GV Prakash, welcome. Welcome, Prakash. Prakash is the head of the Department of Surgery at Tirupati. I know you came in late, so
yes, sir.
Any comments?
No. We extensive coverage is very nice, sir. Really enjoyed the talk.
Anyone else want to comment before we close? Please unmute and comment. I think Saturday is, as Dr. Santosh says, because Saturday is a day for the family and in a combined dinner or whatever. Thank you all so much. And then I shall discuss with Dr. Selvi for another possible day in the week, and it will be a lot more structured than what it is today. Thank you, and we'll see you again. And actually, the future programs will again be written in Learning General Surgery and will be communicated to as many as possible. Thanks once again. Thanks for the evening lecture.
Thank you very much, sir. It's our pleasure. Thank you, Selvi madam. Thank you.
Thank you, sir.